I'm pleased to introduce our next speaker, Sean Bagshaw from the University of Alberta, who's going to talk about kidney-ventilator interactions and kidney protective ventilation.
Thanks so much. Last of the day, keeping you away from the bar. We'll try to keep this at 15 minutes or so. So I'm going to speak a little bit about kidney-ventilator interactions. I have these disclosures, nothing of which is relevant to this presentation. Whoops. Can I go back? So I want to spend a little bit of time talking about the physiological effects of mechanical ventilation on kidney function, some of the physiologic effects of injurious mechanical ventilation on kidney function, and some of the interventions that could be used to potentially mitigate the detrimental effects of mechanical ventilation on the kidney. So at a high level, really, there are key physiologic mechanisms that alter kidney function with mechanical ventilation, and particularly the application of positive pressure ventilation and PEEP. So these include alterations to cardiovascular function, cardiac output, renal blood flow, IVC and renal venous pressure, systemic venous pressure. Dovetails nicely with the end of Andy's presentation. Alterations to neurohormonal activation, including sympathetic, renin, angiotensin, aldosterone, natriuretic peptides, and arginine vasopressin. And then the third is really the exaggerated effects that may occur with mechanical ventilation, and some of these might be relative decreases in effective circulating volume, myocardial performance, altered compliance in the chest, but also ventilator-induced lung injury. And this was a nice review article that spoke specifically about some of the independent mechanical ventilation effects, but also the effects amongst patients and how ventilation may be compounded in the setting of ARDS, and all the physiologic effects that may be transmitted down to the kidney and contribute to losses of kidney function and/or kidney injury. Now, I want to go back to physiology. I always like to show slides and PDFs of slides before I was born. But this gets a little bit at some of the early physiology bit. So this is a simple experiment in subjects that were applying positive pressure ventilation for 30 minutes at a time, 10, 20, 30, 40 millimeters of mercury. Now, I don't know if anyone here has ever worn a CPAP mask at 10 centimeters of water, but I can barely breathe with that. 20, 30, and 40 would be a lot of positive pressure ventilation. But what this experiment nicely showed was that very quickly, there was reductions in urea clearance, and urine output. So there was clearly an early hemodynamic effect that modified renal blood flow in all likelihood and modified the clearance of urea and urine output with the application of positive pressure ventilation. And this is a similar study as well, but basically showed that short-term positive pressure ventilation with PEEP in particular, yes, decreased urine output. It actually was associated with reductions in sodium clearance, reductions in GFR and renal blood flow. But there was actually transient and reversible changes in neurohormonal activation, including plasma renin activity and arginine vasopressin, that once the positive pressure ventilation was released, these actual hormones decrease fairly quickly. In my view, the early hemodynamic effects can occur within minutes to hours, and the neurohormonal effects occur a little bit later. Now, this, again, dovetails with the importance that you might want to place on central venous pressure. But this is another experiment where basically it was an experimental study in dogs looking at PEEP application, but also alterations in systemic venous pressure. And what they showed is that if you raise the PEEP, you will actually decrease renal blood flow. If you raise the PEEP and add an increase in renal venous pressure, you'll compound that. So at high levels of PEEP and high levels of renal systemic venous pressure, you will see dramatic decreases in renal blood flow. If you release the PEEP, you will actually, to some extent, recover renal blood flow by close to 50%. But even releasing the renal venous pressure, it shows that it's a major contributor. So PEEP may be a little bit more important in this context, but systemic venous pressure, CVP, renal venous pressure, renal venous congestion is an important mechanism, and it's one of the mechanisms by which invasive mechanical ventilation and positive pressure ventilation will have an important role on the hemodynamic function of the kidney. What about just like epidemiologic data? So there's a nice systematic review that's really shown the application of invasive mechanical ventilation in and of itself is an independent risk factor for acute kidney injury. And this was shown in a nice pooled analysis of around 30 studies. and showed that it was associated with an odds ratio of 3.6. So significant increase in the risk of AKI with positive pressure ventilation, invasive mechanical ventilation, than without. Now, they tried to dissect down a little bit further to say, oh, is it about the tidal volume, high versus low tidal volume ventilation, or high versus lower PEEP? This doesn't really correlate with the animal physiologic data I just showed. So in observational data right now, they didn't really find a strong signal to suggest that that was what was discriminating the incremental risk of AKI amongst those receiving invasive mechanical ventilation. Now, going back to some animal studies now, if we look at high versus low tidal volume applied to mice, and we actually injure some of those lungs with instillation of hydrochlorothiazide, you can see with the red arrows, here you can see that high tidal volume and an installation of a lung injury was actually associated with a significant increase in the extrapulmonary detection of inflammatory mediators in renal tissue. So here you have distant organ injury incited from the lungs in the kidneys associated with high tidal volume and an inflammatory injury to the lungs. So here's some distal organ effects that, injurious mechanical ventilation may have some predisposing effect to on kidneys. And this is some elegant experiments that were done 20 years ago now, 25 years ago even, post hoc evaluation of patients enrolled in ARDSNet trials, or sort of ARDS trials, looking at conventional versus lung protective ventilation. And what they showed was the effects on multi-organ dysfunction at 72 and 96 hours. So you can see in the figure on the left that the one organ that seemed to have the exaggerated effect at 72 to 96 hours was distant organ kidney effects of injurious mechanical ventilation compared with non-injurious mechanical ventilation. So the kidney was an exaggerated effects to some extent. And this has real important implications, right? So this correlated with higher systemic levels of IL-1, TNF-alpha, IL-8, and other inflammatory mediators. But it would imply that lung protective ventilation in patients who have ARDS may be able to mitigate some of the so-called biotrauma related to ventilator-induced lung injury that has distant organ effects, particularly on the kidney. And there was a follow-up done as well by the same group in Toronto, looking at in vivo animal and human studies using plasma that had been stored from patients who were receiving injurious mechanical ventilation. And they looked at, again, at the injurious mechanical ventilation inciting end organ epithelial injury, particularly apoptosis and other sort of microvascular, microepithelial changes in the kidney tissue. And you can see in the figure on the right that clearly injurious mechanical ventilation was associated with an incremental risk of kidney-related detection of that apoptosis. And you can see some micrographs here showing that injurious mechanical ventilation clearly associated with more apoptotic epithelial cells and membranous debris and apoptotic epithelial cells in the electron micrograph. So again, this is having strong implications about the strategy we use to provide invasive mechanical ventilation, particularly in those with lung injury and ARDS, can actually have real end organ effects, particularly on the kidney, which seems to be the most vulnerable. What about the association between acute kidney injury in those receiving invasive mechanical ventilation and pulmonary mechanics, right? So this study nicely showed that patients who receive invasive mechanical ventilation and develop AKI have a higher risk of death, spend longer on a ventilator, spend longer in the ICU compared with those that did not develop AKI. But what's really intriguing is if you look at respiratory system mechanics, those that had AKI either before or during invasive mechanical ventilation showed that they had higher plateau pressures on average, they had higher or lower compliance in their respiratory system, and they needed higher driving pressures. So the interaction between the lung, the injured lung, the mechanical ventilator, and the kidney is really important, and these patients were actually having sort of decreases in their respiratory system mechanics as a consequence of that. What about just looking at the risk of AKI amongst those with ARDS? And this is another sort of nice study done by Michael Darmon and colleagues in Paris. But clearly, if you have ARDS, your risk of acute kidney injury is 11-fold higher than if you had no ARDS and not receiving invasive mechanical ventilation. So certainly there's a risk with invasive mechanical ventilation, but that's even further exaggerated amongst those with ARDS. And it's interesting, if you look again at these patients with ARDS and developing acute kidney injury, there are differences in their respiratory system mechanics. And you could speculate why that may be. So the acute kidney injury state, there's fluid accumulation, there's acid accumulation, there's other phenomena that you rely on perhaps the respiratory system to help compensate for, or may adversely affect the respiratory system. So here you can see that tidal volumes were higher in those with AKI, minute ventilation was higher in those with AKI, and you can see fluid accumulation over time was much higher in those with AKI who had ARDS at baseline. And naturally, these patients had, the more severe their AKI, the worse their outcomes in terms of ICU hospital, 28 and 90-day mortality. So AKI is really common in ARDS. So this study would suggest around 2/3 of patients at least, with a median onset around 2 days. But what's clear is that it progresses over time. And there's probably a wide range of reasons for that I introduced at the beginning. There's physiologic reasons, hemodynamic reasons, neurohormonal, but then all these inflammatory reasons start to set the stage a little bit later. Older data from Kathleen Liu and colleagues looking at some of the ARDSNet data, but clearly showing associations in patients with lung injury and ARDS and high inflammatory mediator levels circulating in the blood and association with acute kidney injury. If you go back to the original sort of ARDSNet trial looking at low tidal volume versus traditional, conventional tidal volumes at the time, they did show some difference in number of days without non-pulmonary organ system failure. But if you go deep into the supplement, you'll see actually there is a difference in renal failure-free days between the two groups. So more days free of renal failure in those receiving low tidal volume ventilation than those receiving conventional volumes as well. And it brings forth the FACT trial. So the FACT trial looking at 2 strategies for fluid management amongst patients with lung injury and ARDS receiving invasive mechanical ventilation. Conservative really focused around not giving a lot of discretionary fluid, and after initial resuscitation, using diuretics and other strategies to try to aim for a neutral fluid balance, whereas liberal at the time was whatever the standard of care was. Clearly, over the first 6 days, there was a huge difference in the amount of fluid that had accumulated in these 2 patient groups. But you can see here, there was this suggestion of fewer patients in the conservative group going on to renal replacement therapy. And it's speculated why that may be, but it may be for rescue for fluid accumulation-related phenomena, including refractory hypoxemia. What's interesting is that Morgan Grams and colleagues did a secondary analysis of FACT of the 300 or so patients that had acute kidney injury. And what they really showed is that these patients were different than the patients without acute kidney injury. They clearly accumulated more fluid, whether they were in the conservative or liberal group, and they clearly received more diuretics, whether they were in the liberal or conservative group. But what was clear is that the fluid accumulation was far less in the conservative group and those with acute kidney injury, and the exposure to diuretics, both daily and cumulative over time, was far greater in those that had been allocated to the conservative fluid management strategy. So less fluid accumulation, more diuretics seem to be associated with a survival advantage in these patients, at least in this post hoc analysis. What was interesting to me was that there was no Lasix dose above which mortality signals seem to increase in those in the conservative arm with acute kidney injury. So here is another consideration as well. Once we place a patient on a ventilator, we were probably worried about getting them off the ventilator. And this was an elegant study done by a colleague of mine in Brazil, Jose Wara at Syro-Lebanese. And they really looked at the interaction between those who are receiving mechanical ventilation, developing acute kidney injury, and the weanability, if you like, the ability for us to get them off the mechanical ventilator. And again, you'll see those in the AKI group had some differences in their respiratory system mechanics and or parameters, right? Higher PEEP, higher FiO2, higher minute ventilation. And these patients ultimately spent more time in the ICU. But what was important, and it's illustrated in the graph, is that these patients required a longer period of time to successfully wean from invasive mechanical ventilation compared to if they did not have acute kidney injury. This is some data that's actually come from the ATN trial as well. So here you have more intensive versus less intensive renal replacement therapy and its effect on the duration of mechanical ventilation. What's interesting to me is that the more intensive strategy actually had fewer ventilator-free days and a higher probability of being reintubated. So these patients in the more intensive strategy had a 33% lower hazard of successful extubation. And it remains to be understood exactly what the precipitating factors there, but is it related to phosphate depletion and respiratory system, neuromuscular strength, et cetera? It's one of the sort of plausible explanations that may be accountable for that. What are the strategies we can think about in mechanical ventilation and its effects on the kidneys? I've kind of gone through these, but spontaneous breathing versus APRV, not really been looked at, but some early suggestion that maybe there's preservation of renal blood flow and function with spontaneous breathing versus controlled modes. Lung protective ventilation, I think I've shown you lots of data on that lung protective ventilation may reduce the risk and/or incidence of AKI. Conservative fluid management obviously seems to be associated with some better hazard or lower hazard for death and maybe lower utilization of renal replacement therapy. I didn't show the data on neuromuscular blockade and lung protective ventilation in early ARDS. There's beneficial effects that have been suggested on lungs and distant organs, but the kidneys were actually not really well profiled in any of those ARDS trials. And then prone ventilation as well, it's uncertain. But the increase in intra-abdominal pressure in a supine position, I'm not sure what the effects have been on kidney function. And it's, again, not really well described as an important end organ or distant organ that seems to suffer a lot of damage related to inflammatory injury from the lungs. It's surprising that very few ARDS trials have actually focused on AKI as a bystander organ that may be of importance to target. So in the end, my takeaway points for you that early hemodynamic effects followed by neurohormonal and immune-mediated effects with longer exposure may be part of the mechanisms by which mechanical ventilation adversely affect the kidney. Injurious mechanical ventilation can incite indirect inflammatory injury to the kidneys and kidney injury and AKI. And then evidence from clinical trials imply that low tidal volume ventilation lung protective ventilation and conservative fluid management strategies may mitigate some of the adverse effects of AKI. Thanks very much.
Thank you very much for that talk.